Thank you very much. I'm going to talk for about 20 minutes on a book that I wrote with my long-term collaborator, Laurent Einev, that came out this summer. It's very different than anything we've done before. Matt was overly generous in describing my academic work, but all we'd really done is very focused, narrow academic work, and this was our attempt to step back and say, freed from political constraints, but obviously keeping in mind important economic constraints, how can we better redesign the US health insurance system? And so I'm just going to go very quickly through the main parts of the book. The first part is what's the problem? The second part is, okay, if we're going to try and fix those problems, we need to articulate the goal of health insurance policy, which I think is oddly not done in a lot of policy discussions, including health insurance policy. What are we trying to do? Are we trying to improve health? Are we trying to help the poor? Are we trying, what is the purpose? And then I think if I can persuade you of that, and hopefully I will, then the solution, which I'll spend some time on, is startlingly simple. So let's start with the problem. I think everyone is aware that we're the only high-income country without universal health insurance, and that 1 in 10 Americans under 65 lack formal health insurance. I think a statistic that people are much less aware of, we certainly were, is that that masks the much larger share of Americans, 1 in 4, who will spend some substantial amount of time without health insurance over a 2-year period. So, and that's, half of them will spend 6 months or more. So these are people who had employer-provided coverage but lose their job or change their job or retire, or people who have Medicaid, the public health insurance program for the elderly, but fail to recertify and lose their coverage that way. So I want you to keep in mind, first, there's the problem of the uninsured, but second, there's the problem that insurance, whose very purpose is to provide some modicum of security and stability in an uncertain world, is perversely itself highly insecure and unstable. And that's a problem that affects not just the 1 in 10 Americans who are uninsured at a point in time, but the vast majority of the remaining 90% of Americans who are fortunate enough to have insurance at some moment but risk losing it. And the third problem I want you to keep in mind is that even though even if you're fortunate enough to have insurance and to maintain that insurance when you get sick, you can still face catastrophic medical bills that you have to pay for your so-called covered care. So a statistic that a bunch of economists produced right before the pandemic is that there's an enormous amount of medical debt in the United States. The estimate is $140 billion held by collection agencies. That's more than all the total consumer debt for non-medical sources combined. And what Laurent and I calculated that we found sort of shocking is that 3/5 of that medical debt is incurred by people who had insurance at the time that they were incurring those expenses. So these are people with high deductible health insurance plans through their employer, or a Medicare policy that has you have to pay $1 in every 5 for your doctor visits with no cap in sight. So that is also, I think a very big, so those are the 3 problems that we wanted to solve. And we might have, we started with the instinct of, well, maybe we can just do incremental reform. We can extend coverage to the uninsured. We can, regulate the high deductibles, et cetera. And as we discuss in a great detail in the book, and in the interest of time, I'm not going to go through it in a lot of detail, that's like the history of our health policy in the United States is, one particular problem or group becomes salient and a patch is put on to fix their insurance coverage problem. It obviously does help, but it's never sufficient. And I think one of the statistics that I keep in mind that really drives that home to me is that if you think about the people who are currently uninsured at any given moment, those 1 in 10 Americans under 65, 6 in 10 of them are actually already eligible for free or heavily, heavily discounted health insurance. They're just not getting it because they may be unaware of which program they're eligible for, or they don't know what they need, or they're unable to assemble the documentation to get covered, or they do, and then they don't realize they have to recertify, because whenever there's a path to coverage, you have to constantly document that you're eligible. A lot of these programs are actually disease specific. We have separate programs to cover people with breast cancer and cervical cancer, with end-stage renal disease, with Lou Gehrig's disease, with tuberculosis, HIV, most recently COVID. The list goes on. And they have the perverse feature that not only do you have to be sufficiently sick to get coverage, so you don't have coverage while you might be able to nip the disease in the bud, but in addition, if you're fortunate enough to recover, that's great for your health, but then you lose your health insurance coverage. Okay, so we talk about this a lot in the book, not only because we think it reveals part of the futility of an incremental approach, but it also underscores what is it we've been trying to solve. So what is it we have with all these different programs been trying to do? Because as I said, we think very strongly that if we're going to try and fix these three big problems, the lack of insurance coverage, the insecurity and instability of insurance coverage, and the high risk of out-of-pocket costs despite insurance coverage, we have to say, well, what is it we're trying to accomplish with all of these policies? And I think both the history of our country that we talk about, the history of hospitals in the United States, as well as this policy history makes clear that, as we argue in the book, the primary purpose of health insurance policy has been to ensure essential access to medical care regardless of resources. Now, that may sound like a very strange thing to claim has been our goal in a country that famously does not have universal health insurance, and that also, argues for rugged individualism, people lifting themselves up by their bootstraps. But we argue that actually that represents the failure of our policies, not the failure of the intent. I think, as I said, we spend a lot of time on this in the book, but just to give you two quick examples, one from history, Charles Rosenberg, an eminent historian of medicine who has a terrific book on the history of hospitals in the United States, points out that they developed at a time when medical care couldn't really do anything in the early 19th century, and they were primarily charitable, not medical institutions, designed for this notion that we couldn't allow fellow creatures to die in the streets. In modern times, that's been codified into our public policy. So we argue in the book that although there are many problems with our system that we've just articulated, no one is literally uninsured. Why is that? What would it mean to be actually uninsured? It would mean that any medical care you got, you paid for. And that's not what happens. Work that I and others have done from the Oregon health insurance experiment that Matt was alluding to shows that the people who are uninsured still get about 4/5 the medical care that they would get if they were insured. And they pay for only 20 cents on the dollar of that care. If they were actually uninsured, they'd be paying for dollar of that care. And the other 80 cents is coming largely from public funding, public programs, publicly regulated and funded programs designed to ensure that when someone is sufficiently ill and sufficiently impoverished, we then step in to try to provide essential medical care. If you accept, and as I said, we spend a long time in the book making the case that this is what we have been trying to do, then the solution is startlingly simple. It's been recognized across the political spectrum in modern times. It's actually been recognized going back to the very dawn of the Republic and to Alexander Hamilton, whom you all know well, who actually, the United States, actually enacted the first compulsory national health insurance, tax financed, in the United States in 1798. It was 6 cents per sailor per month at sea. It was for commercial sailors, levied when they came into port, and it was used precisely to fund the local hospitals where they had become a burden because they would arrive at port sick, precisely because we were unable to prevent ourselves from helping them. So we should, actually just recognize we're going to do that, collect the money from them up front, and use it to fund healthcare. And that's exactly what in modern times has been advocated for across the political spectrum. Scholars at the Heritage Foundation who supported the Clinton proposed mandate in the early 90s, Republican Governor Mitt Romney who enacted a mandate for health insurance in Massachusetts in 2006, arguing that since ultimately people who are sick and don't have health insurance and are sufficiently poor end up getting care that's publicly financed, we might as well formalize that and fund it up front, to everyone from the more progressive Ruth Bader Ginsburg and upholding the constitutionality of the mandate for health insurance under the Affordable Care Act. The final thing I want to say before getting to the solution is that we think it's important to be clear on what health insurance policy is designed to do. And as I said, what we argue in the book is that it's designed to ensure access to essential medical care regardless of resources. But it's also important to be cognizant and humble about what health insurance can't do. Health insurance policy and the policy that we're going to propose we think is very important, but it's not a panacea and it's not the solution to all our problems. And in particular, for those of you who are, rightly disturbed about both the poor levels of health outcomes in the United States and the shocking disparities in health that exist across the income distribution and across individuals of different races. There's a statistic that, there's about a 15-year gap in life expectancy between a 40-year-old man at the bottom of the income distribution and at the top. One thing we spend a fair amount of time trying to make clear in the book is that health insurance policy is not the solution to that problem. There's an enormous amount of evidence that suggests that, well, yes, health insurance can improve one's health. The magnitude of those effects are just too small to make any dent in these shocking health disparities. I think the single most compelling piece of evidence of that comes from work that researchers have done in other countries, such as Sweden and Norway, which have not only universal health insurance, but much more extensive cradle-to-the-grave safety nets than we have in the United States. And even there, and despite their much more compressed income distributions, you see differences in health between the bottom and the top of the income distribution in those countries that are as large as they are in the United States. So that's indicative of the fact that something besides access to medical care is driving these health disparities. It doesn't mean it's not amenable to public policy, policies that affect exposure to pollution, cigarette taxes, and many types of policies may actually reduce those disparities. It's just not health insurance policy. And the reason is related to the fact that, as I said earlier, no one is actually uninsured, right? So it's not that, it's the fact that people who lack formal insurance are still getting a large amount of medical care without paying for most of it themselves. So it's not that medical care isn't important to health. Of course it is. It's just that the difference between the uninsured and the insured, or the better insured and the worse insured, in terms of driving health differences is not that large. All right, I went through all that pretty quickly. We spend a lot of time on in the book, but everyone from our publisher on down told us that we had to get to the solution. So let me do that in the last 5 or 10 minutes. As I said, if I've persuaded you, or if you read the book afterwards and are then persuaded that the purpose of our health insurance policy is fundamentally to ensure access to essential medical care regardless of resources, and that we aren't currently doing that in the United States, the solution, I think, becomes startlingly straightforward. It has 2 parts. I can fit it on a slide. We'll get it down to a bumper sticker shortly. The first part is universal, automatic, basic coverage that's free for everyone. And the second is that's to ensure access to essential medical care for everyone. And the second is the ability for those who want to and are able to afford it to be able to supplement with additional coverage beyond the essential in a well-designed and well-functioning market. I want to spend, economists love to talk about how to design well-functioning markets. So, that last part is, of course, near and dear to my heart, and it's covered in the book. But in the interest of time, I want to focus I want to focus primarily on the first part, because each of those parts, the automatic, the universal, for sure, but then the automatic, free, and basic are each very important. So the automatic, I think, is the most obvious. We've already enacted universal health insurance coverage in the United States. We just haven't achieved it. Mandating it, it turns out, does not make it so. And so if you want everyone to have access to essential medical care, we need to make it automatic, the same way that when Medicare was enacted in 1965 for the elderly, hospital coverage and, for the most part, physician coverage was automatic, and everyone got it. All right, let me talk then next about the free, because I think arguing that this health insurance should be free, which means no co-pays, no deductibles, no out-of-pocket spending, is about as close as you can come to professional heresy as a health economist. But we make this case in the book. We talk about the history. This is like a Kennedy-Nixon debate with that other Kennedy, Ted Kennedy, over precisely whether or not they were both proposing universal health insurance, but whether it should be free or not. There's a huge, there was a debate at one point half a century ago about whether or not if you made people pay something for their health insurance, for their health care, they would use more or less, they would use less of it. And the answer from economists, including work that I and others have done, is a resounding yes. It is true that if you make people have some financial skin in the game, they will use less health care. And economists have used, myself included, have used that to sort of preach to generations of students that therefore health insurance should have some cost sharing in it. In this book, we say categorically that we take that back. We take it back in the context of universal base. Well, I'm getting applause. It's not from the economists, that's for sure. In the context of universal basic coverage, and before you give me a standing ovation, let me be clear. It's not because economists were wrong about the facts. I stand by those, and the legions of economists that have produced them. It's because we were wrong about the implications. And the reason we know that is from seeing what has happened in countries around the world that have universal basic coverage, that have followed the advice of generations of economists, and faced with budgetary pressures, introduced copays and deductibles into their basic plans, even small ones, little bits for prescription drugs, for doctors. What has happened in country after country is they introduced the cost sharing with one hand and the exemptions with the other hand. So for example, in the UK, which introduced co-payments for prescription drugs, they also introduced exceptions. If you're poor, if you're old, if you're young, if you're a student, if you have cancer, if you're a veteran, the list goes on, so that at the end of the day, 90% of prescriptions in the UK are dispensed to people who are exempt from the cost sharing. So again, and we give many other examples in the book, the point is that if we're going to be designing this program to provide access to essential medical care, there always are going to be people who can't afford even a £5 or €5 copay, and we're going to be forced to make these exemptions and exceptions, so we might as well just skip the equivocation and make it all free from the beginning, because cost sharing doesn't reduce healthcare use when it's exempted. Now, it's fun to get up here and say automatic, universal, free. I do want to emphasize, however, that what we're proposing will be quite basic, and that's what's going to keep the cost to the taxpayer down. In fact, we argue in the book you can do our plan without raising taxes at all. And this is, again, it's going to be basic on all of the, desirable but not essential aspects of medical care. That includes amenities like private rooms. It includes having longer wait times for doctors than we're accustomed to with private insurance, closer to what you experience on Medicaid, and less choice of your doctor, et cetera. We give the analogy in the book to budget airline travel. Those who want more can upgrade. We estimate that about 70% of the population will buy the supplemental coverage. For those who are uninsured, they're unambiguously better off with basic coverage. For those who currently have Medicaid, they'll be better off because there's no risk of constantly losing that coverage. For those who currently have private insurance or Medicare, they're better off on some dimensions, no risk of catastrophic medical bills for their so-called covered care, and no risk of losing that insurance if they lose or change their job, but it will be much, much more basic, and therefore we expect that they will supplement. I'm almost out of time, so I will say that as we discuss in the book how we can afford it, we also did discuss the design of the supplemental program and how to make sure it doesn't erode the adequacy of the basic program. And then the final thing I want to say is probably the question that is on many of your minds, which is, how would we ever achieve this politically? We discuss that in the epilogue, which I think is the right place to have that discussion, because if nothing else, one thing I'd really like to emphasize is I think it's very important to try to articulate the ideal before we start figuring out whether we can accomplish that or some variant of it politically, because if we don't know where we're trying to get to, we don't know which compromises are important and which we can live with. So I'll just stop there and we'll open it to discussion. Thank you very much.
It is an incredible honor to be up here with this esteemed group. It's unclear what I can possibly add to this, so I'm going to basically try to stay out of the way. The one thing I'll say is I think these are for sale. Amy's too modest to do this, but I will say this, having read it, I wrote this down so I would get it right. It's accessible, it's true. It's a page turner, and it's important all at once. So we have Mark, we have two excellent panelists here, And I thought I would start with Mark and ask one key feature of Amy and Laurent's proposal is something called basic insurance. They go to great lengths to say 70% of people buy supplemental, so they must have some idea what's in basic, but they also try and hide what's in basic. So what in practice, as someone who is a researcher and been a policymaker, what would this look like in the real world?
Well, first off, let me say thanks to you all for bringing this event together. It's great to be on stage with Amy. This is the most economists I've been on a panel on since the earlier days of my career, before I did all that political and government stuff. So I feel like coming back to roots. I did want to try to bring in a side of political and policy reality here. I think that the book is a terrific discussion of why basic essential medical care is, I think, the arc where the United States is headed to. But in terms of getting from here to there, I don't want to talk about the past. I cannot, great history of what went wrong in the path to universal health insurance in the United States. But do want to talk a little bit about going forward. And in any political discussion of expanding health insurance, reforming health care, the number one talking point is always first, don't tear it down. You can keep what you have if you want it. So that's been, you can keep your doctor, you can keep your health insurance, you can keep your arrangements. That's been the case ever since 1990, which I think was before my time a bit professionally, definitely before most of the people in this room's time. Remember, the Congress passed a bipartisan bill called the Medicare Catastrophic Coverage Act then, which provided a more generous benefit than Medicare finally got around to providing, and provided protection against those very high costs, following what the economist who advised then President George W. Bush said should be done. And that bill was repealed less than a year later by a groundswell of opposition from Medicare beneficiaries who had actually done the math. They were getting some supplemental coverage on their own. They were being taxed to pay for the new benefit, so they were relatively healthy, well off, and did turn out worse off. And Amy went through in the book and her presentation how most people would be better off if we went to some kind of basic coverage design, but there are a significant number who I think wouldn't be, and that's been a real challenge for every political effort to expand coverage since then. Most recently, the Affordable Care Act, President Obama, 2010, went out of his way to say, if you like your coverage, you can keep it. The Republicans found one kind of small exception to that among these very limited plans that weren't for large employers, that were sold in certain states where people did have to lose coverage. It was on every ad that fall, and big losses for the Democrats in the midterm elections, and maybe that would have happened anyway. But the point is that there is underneath all of this a desire to cover what really matters to people. I think what would be good to talk about tonight is some pathway for how the U.S. can actually get there. If you think about what would go into an essential package of benefits, there are different ways to do it. Historically, countries like England have focused on having a national expert body decide what's cost effective enough and what isn't. The United States has definitely not gone in that direction. On the other hand, if you look at what's actually in our public insurance programs today, which don't cover everybody, but kind of reflect the idea that's required under the Affordable Care Act, President Obama's legislation for all plans, that they have to cover some minimum set of types of benefits. So emergency care, primary care, some preventive services, drugs, some rehab services, et cetera. But it's pretty general about how to do that. And the most popular and fastest growing forms of public health insurance in the United States are basically overall person level amounts of payments in Medicaid or in Medicare, what's called Medicare Advantage, that gives each individual a chance to have some choice in the insurance plan through which they get this set of benefits, and then a lot of work inside that insurance plan, for better or worse, but I think increasingly individualized care that reflects preventive services and interventions for diseases and the like. And that's what's growing the most in terms of types of insurance in the United States. And if you thought about, well, could the US get there? Probably the best path is some version of expanding these kinds of insurance plans. Medicaid through capitated plans, or Medicare through Medicare Advantage.
What does that mean? That's like every man, woman, child gets $10,000 to spend on whatever they want in health insurance?
Well, that's kind of the way the Republicans, I think, would present it. I think the way that Democratic supporters of these reforms would describe it is, well, it's an amount of money, but it should be higher or lower based on how risky your health is. So risk adjustment is a big part of these coverage systems. And there's also some oversight. It's not just, here's a check in a phone book, or as these programs used to be criticized when we were implementing the first version of this. It's a lot of government oversight, transparency around at least some measures of quality of care and complaint rates and access to care, and some choice in those programs. And again, more flexibility in being able to cover certain kinds of services, often without copays, for people that if you tried to do this through, coming up with a list of what's covered and what's not, it would be very hard to keep up with the changes in medical technology, very hard to personalize to the different needs of, how people might want to spend that kind of money on their behalf while still meeting some general essential coverage requirements.
Amy, do you want to respond to that, or I have a question? I very unfairly, both Mark and Josh are excellent at policy and at research, and so I was going to unfairly slot Mark into policy in the beginning here, and now unfairly slot Josh into the academic research, and ask if you had any high-level reactions to the book before we let Amy respond. But if you wanted to say something quickly, Amy, go ahead.
No, I've said enough for the moment.
So Amy, Matt, in his introduction, mentioned one of your earlier papers on the aggregate effects of Medicare, and I want to put that in the context of some other early work you did on the return to capital versus labor. When Medicare more generously reimbursed capital versus labor, that naturally shifted the incentives for hospitals and how they chose to organize their production. More generally, the point that a fair amount of research supports is that supply responds quite strongly to the different sets of incentives that policy creates for it. And so when you talk about taking the 9% of GDP that we spend on public health care and redistributing it to ensure that everyone has basic adequate coverage, but no more than basic and no more than adequate, that means we're not going to put all of this money into the latest technology, into the fanciest hospitals, into the more expensive doctors, because as Mark's been talking about, when we have a budget constraint, we're going to have to make some cuts. And that's going to mean we're going to have less investment, less innovation. So my question for you is, should we decide, and who's going to decide, how to ration dialysis? Should we have eliminated the amazing innovation in COVID drugs over the past year? Or more generally, the massive spur to pharmaceutical innovation that came after the an acronym. Yeah. The Medicare Modernization Act of 2003. Which of these do we want to take away in order to ensure that we have this basic level of not so great healthcare that's exactly uniform across the board?
Okay, these are. Am I allowed to respond now?
Yeah, you're allowed to respond.
These are great questions. Thank you both very much. Let me say one thing that both of your comments highlighted, which we highlight in the book, but perhaps I didn't in the talk, and so I'm glad you did, is the other key element of our plan is that basic coverage have a budget, right? And that is both a really banal comment, like what government program doesn't have a budget, and a totally radical comment, because the government program that doesn't have a budget is the U.S. healthcare program. When we talk about the Medicare budget, we mean how much Medicare spent last year or how much we think it's going to spend next year, not an actual budget constraint. And so we do find that the only way you're going to keep this program from unintentionally growing, and the only way you can start to make the hard choices about what is in basic coverage is if you have, as every other country does, a budget. But then to Josh's rabble-rousing comments about, yes, I understand supply curves slope up. You've taught me that in healthcare. But again, just to be clear, that's in the basic plan. You can think of the basic plan, since Michael wants to be clear on what it is, you can think of it roughly as Medicaid for all, where Medicaid is the public health insurance program for low-income individuals in the United States. About a fifth of Americans are on it. It has, for the most part, no cost sharing or copays or deductibles. On paper, it looks pretty generous in terms of what it covers. It covers a lot of things, but there are longer wait times than in private insurance. There are fewer amenities. There's more of what Mark described of government oversight and regulation and authorization before you can get care. So, but Josh, to your point, whether or not that is going to reduce total healthcare spending and hence innovation or supply is not at all clear, because we do think the other 70% of Americans are going to supplement. So we've been criticized for saying, well, we're not going to solve the problem of how to reduce healthcare spending in the United States, how to get that 18% of GDP number down. And the reason we don't do it is in part because we don't think it's easy to know how, that there are no ways that we know of to radically reduce healthcare spending that won't have potentially adverse consequences that you have to trade off. One of which, one of the things people like to say is, let's get prices down. We pay more for drugs, we pay more for physicians in other countries. Let's increase access by getting prices down. We may want to do that, but it would certainly come at the cost of reduced supply and reduced innovation. Our only point is we don't have to solve that problem to solve the insurance problem, because we're just going to hold the costs down in the basic plan and let the market choose, as it has been doing in the supplemental.
So then why solve the insurance problem?
That is a very fair question. One could unfairly look at our book and say, look, you've kind of said everyone basically has backdoor access to insurance coverage. The uninsured get a lot of uncompensated care. You've just told me that we're not going to solve the problem of high healthcare spending. And not only that, we're not really going to reduce health disparities. So what's the point, right? That would be an unfair criticism. But should you have, should you choose to levy it, I would respond.
Do you get to judge if it's unfair?
No, I mean, I think, at a very simple rhetorical level, I don't, we were urged to not spend much time on the problems with U.S. health insurance, because there's nobody who's going to take the other side of that argument and say we have a well-designed and well-efficient system. I think more specifically, we think that we're punching, with our 9% of taxpayer dollars as a share of GDP being spent on healthcare, we're punching well below our weight in terms of issues like people not knowing which programs they're eligible for or how to get coverage, or failing to stay covered once they're already covered because they haven't sent in the form that shows that they still have low enough income or they still have breast cancer, or they have coverage but they're still facing large out-of-pocket medical bills because of these high deductibles. So the problems we want to solve is to actually turn U.S. health insurance into a program that actually provides access to essential medical care and doesn't risk exposing you to catastrophic medical spending, which I don't think anyone would argue the current system is doing for most people.
Go ahead, Mark.
I'm saying certainly a great goal, and maybe back, since you wanted me to play the policy role. Remember, I am an economist, so
No. So it was only for the first question. I'm not going to.
Well, just to pick up on this one, just as all of the actual debates about expanding coverage come across this stumble over taking coverage away, including generosity of coverage from people who have it now, they also are inextricably linked to cost, because these programs do have additional costs. If you were going to try to expand coverage without raising costs, you have to do something. Bless you to, we got preventive coverage for that. But these debates never happen in isolation. And I actually think that could be a useful feature of trying to make more progress in highlighting just how important it is for everyone to have access to some basic level of coverage. The reason I say that is because the basic benefit, like Amy has been talking about, is something that you can actually use to try to drive improvements in the design of healthcare. So you talked about, Amy, in your remarks and in the book very eloquently about function before form. But as Josh was just saying, function follows form. What you end up paying for, how you structure these benefits makes a big difference. North Carolina, where I'm based now, recently became the first state with a not just Republican, but veto-proof Republican legislature to expand Medicaid. And it did that by a framing of this issue in two elements. One was the fact that this was really necessary to improve access to basic care for all the reasons that you described in the book. But the other was that the way that coverage was going to be implemented was going to be different than the way that these smaller scale, more traditional Medicaid programs have been run, based on fee-for-service payments and costs that couldn't be easily controlled. Instead, it would be under these competitive budget limits on what people would have to spend on their care, with accountability for actually improving things like on your list, like maternal health disparities, opioid use disorder, hospitalization or emergency visits, and outcomes. So it's a different way of paying for care and designing care that was actually essential in linking to the political support for expanding coverage. So I don't think, I get the focus on starting with the basic principle of essential, and I think most people in policy today talk about health care, not medical care, because a lot of things that can improve health and be integrated in the service around people can make a difference. But I think to really make progress, putting the two together, addressing Josh's concern, just how important design is in terms of what's covered and how and what the incentives are. I don't think it's either or. And I think there are a lot of ways in these kinds of more capitated programs that put more responsibility on the providers for limiting costs, place them more at financial risk, not just the insurer, to get to low or no copays, like in some of these faster growing forms of Medicaid coverage.
Yeah, I agree with you. It's not either or, but it's sort of either and, in the sense of we wanted to be clear in the book on what we thought had to be, what were the must-dos in a redesign. And then there are a lot of extremely important design questions around, are we going to have fee-for-service or capitation, or exactly how our plan's going to be designed, where we are explicitly and deliberately silent, because we think that these are actually areas where reasonable people can disagree. Unreasonable people can also disagree. But that there are pros and cons to, single payer versus multi-payer, private insurers versus public insurers versus a mix. And so all of those are possible within the broad contours of what we're proposing. And those could be decided either on the merits, as people argue them out, and or on the politics. And that's a little related to the teardown point, which you've convinced me is not going to sell well politically. So I'll leave it to the people who are going to go off and do policy to repackage that for us. But I think the point is, the Obama line was, if you like your doctor, you can keep it. Right, him or her. Not if nobody loves their insurance plan, right? So we're not saying you can. Yes, your insurance plan may change, but if you are buying supplemental coverage and you want to keep getting medical care the way you are currently getting it, the supplemental coverage can make sure you do that.
Can I ask a question here? This nebulous basic idea.
You notice that Mark didn't define it either.
Yeah, I know. So we have an idea on what it is today, but was your and LaRon's secret agenda? Is this like a Trojan horse to have Canadian or UK health insurance? Because won't basic just grow over time?
You totally found me out. So
who's going to stop it from growing?
Well, so the budget. Or a
whoa, which budget? The budget Congress passes every year?
No. Touche. the budget in the basic coverage. I think, in fact, some of the arguments with the UK system is that it hasn't grown. There's arguments about whether it should grow more or less. You can't even begin to have those debates in the United States because we don't have a healthcare budget. And one of the reasons we don't articulate exactly what's in basic beyond what, as Mark said, the obvious, broad contours, is precisely because what the definition of essential medical care is going to change as incomes evolve, as new technologies are developed, and as notions of what constitute disease evolve. So countries are, including the US and Medicare, increasingly recognizing that mental health is an important component of health and adding coverage for that. And so, Mark described how it worked in the UK, which is probably what people are most familiar with, but some version of that is what happens in every other high-income country except the US, which is A, there's a budget, and then B, for new technologies, there's a group of technocrats who in most countries score it, like in the UK, on cost effectiveness. And then there's a group of stakeholders that think about need and priorities, which is partly cost effective and partly you know it when you see it, and partly politics. And they're all constrained by the budget. And sometimes there's debates about, should we raise the budget? Should we spend less on the military and more on health insurance? It sounds quaint, but they do that in other countries, right? Or should we raise taxes? And I think that's how you evolve to what is covered by basic.
Mark, does it sound quaint to you?
It doesn't sound quaint. It does sound like an issue that would be good to talk about further. So that's why we're here tonight. And as Amy has shown in much of her earlier work, the technology, the innovation, the care that comes along is not, as economists would say, exogenous. It depends a lot on the extent of coverage and the nature of coverage. And that's why I do think these issues are kind of inseparable in terms of thinking about costs, and even more importantly, if you really value health, thinking about how healthcare and health insurance actually translates into health. I'm not quite as defeatist as the slides, doesn't matter much for population health. There are other things that absolutely matter much more, and it would be great to find ways to reprioritize more so the U.S. isn't punching below its weight on health outcomes. But there are absolutely ways to make healthcare work better, to support innovation. And this is also, so that's one issue. I would like to get in the point about, where this is another place where I think economists like Amy could help, is in articulating to policymakers how to make supplemental insurance work well. Supplemental insurance in healthcare is mainly not related to, at least in the US, the additional amenities that you get from your own private room or better meals or things like that. It's additional, it's less time to access to care, and especially it's becoming more and more important in the kind of care that you receive. So for most cancer risks and most cancers, they're now multimodal therapies. Some are more cost effective than others. Many are not very well and not fully understood when they make it to market. And there are very different ways in which insurance plans could handle that. What I haven't seen so much of, and it'd be great to, again, think about how this could actually happen in the US, it could make it more real, is how do you get programs that help people buy up to higher and higher levels of care when a couple of things are going on. One, there are all kinds of economies of scale and scope in coordinating care around a person. So you have like one person a set of healthcare providers who knows them, who can put together the right combination of treatments. I think you were on there's a seminar presentation by one of your colleagues this week, I think at Duke, about cell-free DNA screening tests in prenatal care, which could be part of a very good comprehensive program to improve kids and maternal outcomes. But as you pointed out, it's more cost effective for some people than others, and implementing that is something where you need to put together data, AI, et cetera, around individuals. So how do you make that work? And also with the issues around adverse selection that you've written about as well. So I think the main point I want to emphasize is that the other arc here, besides trying to get to a minimum essential benefit, is an arc to healthcare that's more and more individualized around a person, and more focused on prevention and benefits from data and new ways of paying for care. A lot of those UK cost effectiveness standards are based on a presumption that services are going to be priced at a per unit level. That's not the way you should be pricing drugs. Drugs have very low marginal cost and can convey a lot of value. So there are subscription models, there are other ways of reforming reimbursement that are just hard to do if you have like one level of products that are included for certain people maybe and another level for others.
So, Josh, go ahead.
I was going to build on Mark's comment, if I could.
I have a question for you. Go
Okay.
ahead.
Let me just build on Mark's comment briefly about going to the fundamental economics of what we're trying to do here. Insurance is supposed to be about, at least this is what all the students have heard us say for many years, supposed to be about protection from catastrophic financial risks. And when Mark's talking about the important parts of medical care being prevention and all of that, that's exactly the opposite, right? So why are we talking about a universal, comprehensive care bundle of what we sort of expect everyone to get when most of that is things that people can reasonably be expected to afford for themselves?
Should I answer these questions?
Go ahead, but
You guys have raised a number
it's
of...
your book, but since I have the three of you here, I have my own questions that are unrelated to the book, but I'm desperate to ask the three of you. But go ahead.
I'll be brief.
We'll
So
talk
you guys
about your
have
book.
raised a number of very interesting points, all of which we address in the book. But to just we do. But to just quickly respond to a couple of them.
That's in the online appendix?
Yeah, exactly. So Josh, I think on the preventive and primary care point, you raise obviously a very good economic point. Also, it's probably the place where we do worst in terms of actually providing publicly financed care to the uninsured. And so we struggled a lot with the question of, well, if it's not revealed to be part of what we're trying to do and it's not, should we cover it? And, there are arguments that maybe it saves money, and I didn't want to go there because I don't think we know that it doesn't, but we certainly don't know that most of it does. In the end, what we concluded is that even for the privately insured who have coverage for all of this, primary care is 5% of healthcare spending. So I don't think it's worth spending a lot of time worrying about it, is the short answer on that. And then I just wanted to say quickly, Mark, you raised a number of great points, but on this particular concern of if you separate some services, they're provided by one person and some by another, then the whole coordination of care can fall apart. I just wanted to be clear that there's no reason that for the 70% that have supplemental coverage, that couldn't be provided, and in fact, might well be by the same insurer that's providing the basic. In many countries, the Netherlands, Switzerland, Israel, these are vertically integrated insurers that are offering the basic and the supplemental. So I think that particular issue need not be an issue. But I know you're desperate to law, but...
Okay, so we've got three of the greatest healthcare experts, at least in the American system here tonight. And we're talking that Amy's telling us what we should really care about, and that's great. But what the hell is going on? We spend so much, and life expectancy is terrible compared to other countries. Can we just not evade that elephant in the room for 1 second? What would you guys? Why is it so, and what would you do to change it?
Don't evade that.
Oh, so you're going to Josh.
Me. All right.
So yeah, Josh was supposed to start, yeah.
We give our health system much bigger challenges than most other countries. We run a bunch of people over with cars. We eat a bunch of those sliders that they were serving out before.
Mm-hmm. They're very delicious.
They're really delicious. And we choose to take our higher GDP than most other countries in the form of we got to eat a lot of sliders. We have a country that's...
Is our diet much worse?
Our obesity is much worse.
Our obesity is much worse, yeah. Okay.
Well, some other countries are catching up.
Yeah.
So, but yeah. And
they're learning
there is
from
now medical innovation that is likely to make a material difference in obesity rates in the United States.
We have a geographically very dispersed
we've made ourselves unhealthy.
We've made ourselves unhealthy. We live in a geographically dispersed country where it's hard to provide medical care in all the places that people need it. So we have a harder problem, and I don't think it's fair to say that we get nothing for our spending. We may look like we don't get more than other countries because a lot of innovation is being done here that is then exported. So we spend the money, we share the benefits. That's great. No objection from me for doing that. But it means that, you got to really be careful in how you think about the inputs and the outputs.
Better value-added measures, okay.
Yeah, in other countries, again, it's like what's causing what, but in other countries, it is generally harder to spend more money on healthcare than it is in the United States. And one way of looking at the U.S. system is, well, it's got a lot of gaps and incompleteness. The other is where the U.S. and other countries differ is not in public spending on healthcare, it's in private spending on healthcare, and we make it a lot easier for people to spend more. What we don't do is make it easy for people to spend that money well. And that gets back to the point I was trying to make about encouraging what people want to buy here in healthcare, I think, like in other areas of their life, is more integrated solutions that help make their lives easier and help them get the best access to the treatment for their own particular needs. This is the kind of trend in product development and consumerization and customization that's happening in many other industries, and healthcare is well behind. Anything that tends to fragment services that are covered, services that are not, tends to get in the way of those kinds of more integrated solutions. So there are good reasons for not covering everything, for trying to set limits, et cetera. I just don't think the economists, and this is something that I think economists should be helping with more, have helped lay out a pathway to how to do what Amy's saying in terms of providing supplemental coverage that is efficient, that goes along with these trends towards more prevention. That's what people really want to pay for, and you can't separate health insurance for catastrophic protection from health insurance that keeps you healthy. Is my point.
Okay, so let me bastardize these two answers.
Yeah.
I think Josh was, actually, if you could measure value added, our value added's really good, because we smoke, we drink, we eat, all the stuff. And your answer is, like, can we break it down? It's like if we could just design the incentives a little bit better.
That Americans seem with their revealed preference to be showing that they want to spend more on health care, and we're not necessarily helping them spend that money effectively. But what a lot of other countries have done is made social
But that
choices to
explains
limit.
why life expectancy is so poor.
Oh, I'm sorry. I take it back to the.
Right,
I
no,
take
so
it back to the
that's
life
what I thought was
expectancy
so
one, too.
interesting in hearing your answers to the questions, because you phrased it the way I usually hear it, which is we spend twice as much as a share of the economy on healthcare as any other country, and we have worse health outcomes.
And we still
What's
die.
going on?
Yeah.
And in some sense, if you hear their two answers, they're doing what, which I agree with, is sort of separating them. One is we spend a lot of money inefficiently, and I don't think we totally know how, but you have some, I think.
But the
right
markets
ideas.
Agreed,
Right.
but they've
no,
disagreed.
No, but they're not disagreeing. And
Josh is saying, no, we're great. It's just we didn't
So
bother
I
to
heard
measure
Mark
value
is
added.
saying there's a lot of waste that we could, if we redesigned our policies, reduce healthcare spending without harming health. And I heard Josh is saying, yeah, but that's not we could do that, and that would get the denominator or the numerator of spending down. But in terms of actual health outcomes, the problems are gun violence, cigarette smoking, obesity, pollution, et cetera, not necessarily medical care. So in some sense, we're linking these things together. When
I
they
see.
may
I
not
heard
be.
Josh is like
Let me give you one
value
more
added
answer
is
that
great.
you'll like better, which is, and it relates to what Mark is saying, we don't give people ways to spend what they want. One way in which we do a really bad job of letting people spend what they want is by making competition really hard, making entry really hard. Why do you get waste in any other industry? It's when you have a monopolist who gets lazy, right? And we have that pervasively in healthcare, right? If we think there's so many gaps, why don't we see entrepreneurs setting up new hospitals? Why don't we see new medical schools opening and new doctors competing? There's a bunch of doctors yelling at me on Doximity, which is their social network this week, for saying this in The Economist. But we make it too hard for people to enter medical schools and too hard to set up this kind of integrated different solution, anything that doesn't fit in our current paradigm. So I'm not going to say there's no room for improvement. I think we should take advantage of the supply behaviors that we see out there, but I'm also going to defend the system despite Amy's claim that no one would do it.
Okay, so Amy, have they covered all the answers, or is there anything? Do you have anything to possibly add to this?
I thought I had covered all the answers.
No, I'm asking a different question.
Oh,
So now, if we could just design the system a little better, make it more competitive, and if we actually had the appropriate measure that we don't perform so badly because we're consuming all the healthcare through eating bad and stuff. Do you have anything, what is your insight as to why it looks like to a naive observer that things don't look like they're working so well?
I guess this is going to frustrate you, but I kind of agree with both of them. I agree with, you're frustrated. I agree with Josh that the fundamental drivers of poor health in the US are not in the medical system. But I also agree with Mark that there is an enormous amount of waste in our current medical system, which doesn't mean there isn't also value added. I mean, I think, there's an old adage about advertising, that half of all advertising spending is wasted. We just don't know which half. Yeah. And I think that's kind of true. So advertising is effective, but it could be a lot more efficient if we knew which half to cut. And I think that's actually really true of medical care as well.
Yeah. And there are these social drivers, other factors, some of the things that you've looked at in your earlier JPAL work. It's hard to study them in single point in time clinical trials because the interventions are so dynamic and individualized. But a lot of what's going on in Medicaid and in Medicare Advantage, these programs that are the ones growing the fastest and that I think are most in line with where Amy would like to go in our poor, shadow of an efficient healthcare system here, that are getting more into addressing those kinds of root causes: housing, food insecurity, interpersonal violence, things that you might, well, that's not medical care. But if you look at the needs of certain individuals and families and ask them, effectively, how would you like this healthcare money spent on your behalf? That seems more in line with what would make the most difference for them in their lives.
I think my daughter taught me that this is called intersectionality in other contexts. But, okay, Amy, you get the last question of the night. What is the next book on?
There isn't a next book that I foresee, in part because, as we said at the beginning of this book, when usually people would ask us how should we fix the health insurance system, I'd say, I don't know, that's why I work on it. I don't work on problems that I think I know the answer to. Now I think I know the answer to the health insurance problem. I don't know how to get there politically, but I feel like I know what on the whiteboard is the ideal solution. What I don't know, and I'm not saying, I agree with you, Mark, we know more than I'm implying, but I don't really know the answer to the kinds of questions that have been asked or that you were asking about how do we dramatically lower healthcare spending without, sacrificing a lot on patient side. And that's, at least for the next several decades, that's what I'd like to try to figure out. And if we make any progress, or if others do, maybe someday we'll write a book on that. But I, at least right now, feel like I have a lot of hard work to do first.
Excellent. Well, on that note, join me in thanking Amy, Mark, and Josh.